goals here are to reduce morbidity and mortality, as with every single other disease state that we treat, but we want to also increase our long-term functioning for our patients. So in terms of short-term goals during the acute management, there's 4 in particular that we're looking at. So the first thing is to establish our ABCs, so our airway, our breathing, and our circulation, to essentially stabilize the patient upon arrival. So we really don't have much of a role here. So that kind of happens in the periphery, and then we start action. So with step 2, we see our maintenance of our balance between our cerebral oxygen delivery, so our CDO2, and our cerebral metabolic rate. So a lot of our ways of addressing increased pressure is actually by reducing our cerebral metabolic rate, because that means that we're decreasing the rate of oxygen use. We want to also prevent any kind of secondary neuronal injury, as well as prevent any complications or treat complications associated with it. So again, that refers specifically to our seizures and our DBT. So ICP monitoring, so ICP changes are really the crux of treatment for us in terms of pharmacologic management. So typically our normal intracranial pressure is somewhere between 5 to 15. There are several situations in which we do recommend kind of continuous intracranial monitoring, but intracranial monitoring is an invasive procedure. So on the next slide, I kind of have some images of what that looks like. So we only want to reserve this for severe situations. So if we refer to the 2007 guidelines for treatment of severe TBI, this would be anybody with a Glasgow Coma scale of 8 or less, so again, severe, who also has an abnormal CT imaging of the skull. If they do not have an abnormal CT, then they'd have to meet at least 2 of the following criteria for it to be a candidate for this continuous ICP monitoring. So that would be age greater than 40. If they have motor posturing, it could be either unilateral or bilateral. And also if they have a systolic blood pressure of less than 90, because systolic blood pressure will also have an effect on oxygenation. So remember that our mean arterial pressure also factors in with CPP. As we increase mean arterial pressure, our CPP increases, and vice versa. As we decrease our mean arterial pressure, we also see a reduction in our perfusion. There's kind of 2 ICP monitoring tools that we use most frequently. Our ICP Bolt is kind of our older way of doing it, and EBD, which is a more common use at this point. It's a little less invasive. But in both situations, we are actually cutting a hole into the skull, so it is very invasive, meaning that we are increasing risk of infection. But in this situation, our benefits potentially of having this continuous way of monitoring our intracranial pressure tend to outweigh the risks in this situation. So this is kind of just the schematic of what it looks like. So we're actually cutting a hole into the brain, and then we're going to insert a catheter into that hole so that we can hook it up to a monitoring device so that we can actually assess that ICP on a continuous basis. But again, that's only going to be for those certain cases where it's indicated. Now, in terms of treatment, there are a few threshold values I do want you to be aware of. So these are kind of our indications for treatment for patients. So in terms of intracranial pressure, remember that our normal value is 5 to 15. In the setting of acute TBI, we want to maintain this less than 22. So anything 22 or higher is an indication that we need to treat. This could be either physically treatment, which sometimes can be via drainage of the cerebral spinal fluid. It could be craniectomy, which both of those are not typically recommended, or it could be through pharmacotherapy. In terms of our perfusion, we want to maintain adults somewhere between 50 to 70, and in children, we want to make sure that it's always greater than 40. Also remember, blood pressure plays a big role in our CPP, so we want to make sure that our systolic blood pressure doesn't drop too much. So we want to correct and prevent any episodes of hypotension. So in this situation, for our younger patients, we want to keep their systolic blood pressure 110 or higher. For our older patients, 50 or higher, we want to keep it 100 or higher. So kind of remember that anything less than 90 is very risky. So less than 90 for systolic blood pressure is associated with significant morbidity and mortality. And finally, for perfusion, we want to make sure that we're correcting and preventing hypoxia. So we want to keep this less, we want to identify and address it if it is less than 60. So in terms of pharmacologic treatment of an elevated intracranial pressure, so this is how we improve our CPPs by making sure that our ICP is low. So some of our treatments include hyperosmolar therapy, which in this current state we use mannitol or hypertonic saline. There are some other agents that have been used but are associated with significantly more side effects. So hopefully you will never see them in use, and this is typically very much protocol driven within the hospital. We also can help by decreasing our metabolic rates. So we can use things like sedatives and pain analgesics to address things like pain and agitation to decrease metabolic demands on the brain. We can also use paralytics, as well as we can actually induce coma using barbiturates. So hyperosmolar therapy. So really the principle here is that we're trying to decrease brain volume, which leads to a decrease in our intracranial pressure. So our normal serum osmolality is listed here, so it's going to be somewhere between 275 and 290, but our goal here is to try to increase our serum osmolality above physiological norms. So our goal is to increase it somewhere in the range of 300 to 320, and in this situation we're creating a concentration gradient that allows us to actually draw out fluid from the brain. So it acts as a very potent diuretic. And again, these options would include mannitol and hypertonic saline. So the first agent I want to go over is our mannitol. So this is going to be a dehydrated sugar alcohol. So it provides a large osmotic load. So this causes that diuretic effect to occur. So mannitol does not actually cross an intact blood-brain barrier, and it draws that water out of the brain into the intravascular compartment. So again, alleviating that extra pressure due to that excess volume within the brain or within the skull. So recommended doses are listed here. This is the one situation where I do want you to know doses. So for mannitol, our recommended dose is going to be 0.25 to 1 gram per kilogram. We give it as boluses. So in this situation, we find that boluses work much better than continuous infusions. Some institutions do still use continuous infusions because of the ease of administration, but typically we want to recommend bolus only. So it's given over 20 minutes every 4 to 6 hours as needed, and the doses can be repeated to draw down that ICP. So if you have someone on a continuous ICP monitor, after 4 hours of administration, if you notice that ICP is starting to come back up and it's greater than 22, you can give them another bolus of the mannitol. It does have a very short duration of activity, which is why we can give it frequently. But of course, because it is such a potent diuretic, we want to make sure that we're evaluating osmolality levels as well as our electrolytes. So at the same time, while we can administer it every 4 to 6 hours, we want to check on our serum osmolality and our serum sodium every 4 to 6 hours as well. And we do want to hold mannitol in certain situations, so this is important to note, is that if our serum osmolality is greater than 320 or if our serum sodium is greater than 145, we want to discontinue treatment with mannitol. The reason why is this can cause significant disturbances that can actually result in renal failure. So if you have a patient that's already in renal failure, or it seems like they have significantly reduced renal function, mannitol is probably not going to be the best agent, and that's a situation where you're probably going to choose your hypertonic saline. So hypertonic saline is used in really various concentrations. While it can be used as low as 2%, most institutions will use 3% or higher. If the concentration is greater or 3% or greater, it must be administered via central venous catheter. So that's important to understand too. So if your patient already has a central venous catheter, this is probably a good agent to choose. However, if you have a patient who doesn't already have one and has no other indication, mannitol might be a better option for your patient because it doesn't require that central catheter. It does have a very similar mechanism of action to mannitol, so again, it is a diuretic, but in this case, it uses serum sodium as a driver of that osmolality. So the osmolarity equation is listed for you. You do not need to know this. This is FYI, but you'll probably be asked this if you do any kind of acute rotations or emergency medicine rotations. This is important to know for those. And our goal sodium in this situation is to get our sodium level up to 140 to 150, or 145 to 155. This situation is one in which we can administer it via bolus or continuous infusion. This one is completely the same efficacy across the board, so different from mannitol in that way. So it is a little bit easier sometimes to administer the hypertonic saline because it can be administered via continuous infusion. But we should also note that we don't want to rapidly discontinue the agent, so we have to slowly taper down the dose to discontinuation. So a little bit different from mannitol, where we just give the bolus and then that's it. Now, in terms of choosing an agent, the guidelines don't make a recommendation here. So there haven't been any head-to-head randomized controlled trials showing that one is more efficacious than the other. So this is really based on your institution protocols that are already in place and considering the patient, so patient-specific drivers. So some of the clinical considerations I have listed here are, first of all, does the patient have a central line? If they have a central line, then your hypertonic saline is probably an okay choice. Is the patient hemodynamically unstable? If they are unstable, then we probably do not want to choose mannitol because of that risk for electrolyte disturbances and causing potentially renal dysfunction. Also check, do they have baseline renal impairment? If they do, mannitol is not the best agent. Also can consider if they're volume overloaded or dry, because sometimes we can actually use the hypertonic saline to our advantage in that situation, or it might actually cause detriment to the patient. And also consider what are their most recent serum and osmolarities. In terms of sedatives and analgesics, so this is used to control agitation and pain. So we know if the patient is experiencing any agitation or pain, they're going to have a higher metabolic demand. So if they have a higher metabolic demand in a situation where we can't meet the demand, that's when we see a significant injury. So we can use things like sedatives and analgesics. In this situation, short-acting agents are preferred. So the two that we use most commonly are going to be fentanyl and propofol. Propofol can only be used if the patient is intubated, but most of the time they will be in the situation of a severe TBI. Propofol is kind of our generally used agent. Most of our clinicians prefer this. A few different reasons here. It is really easy to titrate propofol to effect, so it's an easy to use agent. It also has such a short duration of activity that if you were to overshoot the dose, or if the patient started to experience side effects, you can simply discontinue the propofol and that immediately goes away. So it does kind of have immediate on and off switch to it. It also can potentially have some sort of neuro benefit outside of improving agitation and pain. So we actually see that even independent of agitation, propofol can lower our ICP. So again, typically we're using propofol for this purpose, but if the patient does not or if the patient's not intubated, then we can't use propofol, in which case we typically use fentanyl as our alternative. The most common things that we see here that we want to watch out for is hypotension. So remember, hypotension can have a variable effect on your CPP. So if we decrease our mean arterial pressure too much, this can have a negative effect on our perfusion rate. We can also see a high PRIS. So PRIS symptom can happen with high doses of prolonged infusions. Not sure if you guys talked about this in other classes, but this is a really severe situation. So in the situation of PRIS, we can see hyperkalemia, we can see lipid changes, so typically we do recommend triglyceride monitoring. We can see hepatomegaly, rhabdomyolysis, myocardial infarction, and some patients do actually die due to this side effect. So while we can decrease or diminish this adverse drug reaction by immediately decreasing propofol, we always want to be monitoring for the risk of PRIS, and this can happen with the high doses and prolonged infusion. So again, that's why we have a maximum recommended dose for propofol. Paralytics are really only considered if other treatment options fail. In this situation, the patient absolutely must be intubated for airway protection. And then in this situation, we also want to make sure that we're giving them adequate pain as well as sedative medications while they are intubated, and we give them the paralytics. We can use boluses or intermittent boluses or continuous infusion. In this situation, we have a few options that are preferred in our critically ill, but we also want to consider risk of things like hypotension and bradycardia. So this is only after our other agents fail to work. And kind of our final last line way of addressing overactive metabolic function is to actually put the patient into a physiological coma. So this is going to be induced by our barbiturates. So we typically use pentobarbital in this situation. So really, again, we're going to be suppressing our cerebral metabolism, which is going to alter our vascular tone, and hopefully this will decrease the oxygen demand on our central nervous system. So pentobarbital dosing I have listed here. So our first step is to kind of give our initial high dose bolus over 30 minutes of 10 mg per kg. And then afterwards, step 2 is going to be 5 mg per kg. We're going to do that every hour for 3 hours. And then finally, we're going to start our infusion. So this is going to be 1 to 2 milligrams per kilogram per hour. We can kind of give intermittent boluses as needed in this situation. So we will do kind of burst suppression based on their EEG activity. And we can also burst it based on our serum concentration. So we can monitor our serum concentrations, and if it's not within that 3 to 4 range, we can give additional boluses. The most significant adverse drug reaction here is risk of hypotension. We can also see myocardial depression as well as immune suppression, so we want to make sure that we're being very cautious when making the choice to put someone into a barbiturate coma. In terms of treatment of acute complications, I'm going to be focusing on post-traumatic seizures and VTE. So in terms of treatment of the active seizures, our goal here is to reduce metabolic demand on the brain. So again, having a seizure is a huge metabolic demand on the brain. You guys will talk about it a little bit more. We also want to prevent status epilepticus. So status epilepticus, you'll talk about again more in your seizure lectures, but it's the idea of having rapid seizures one after another, and this has a really high mortality rate. So this is a serious situation. It is considered to be a medical emergency, and it's really only treated via IV anti-seizure medications. So when we have active seizures post-TBI, our 2 medications of choice are going to be the IV administration of either diazepam or lorazepam. So again, this is typically institution-based on what they have on formula. You can kind of refer back to our anxiety lectures for pros versus cons for the different agents, but in this situation, they are considered to be equally efficacious for treatment of seizures. In terms of diazepam and lorazepam, there are slightly different doses. These are going to be weight-based IV administration depending on adults or children or infants. So if you have an infant or a child, we are going to be following weight-based, whereas adults, we can kind of follow this fixed dose in the ranges listed for you. So after we use our benzodiazepines for acute management of seizures, we also want to prevent future seizures from happening. So our drugs of choice include phenytoin or fosphenytoin. So you'll talk about the differences in your seizure lectures, but the doses are listed here. So usually what we'll do is we'll provide a loading dose of our phenytoin, which is listed. Again, we have slightly different doses. Both of these are going to be weight-based regardless of whether they're adult or a child, as you'll be discussing in the seizure lectures. While phenytoin is one of those drugs that has a lot of really great evidence for use, pharmacokinetically, it is a very challenging drug to use. So there's a lot of complications associated with it. So you'll see some institutions will choose off-label drugs for treatment of prophylactic treatment of seizures. We also have maintenance doses listed here, which can be given IV daily, and typically we're going to stop giving this about 7 days after initiation of the treatment. Now we also know that just post-traumatic seizures in general, there's a really high risk, particularly in the individuals with these risk factors listed. So early traumatic seizures are defined as any seizure that occurs less than 7 days after the injury occurs. So in the situation where we have post-traumatic seizures, we do want to treat those, but also there's some institutions that will treat or prophylactically administer anti-seizure medications even in the absence of any known seizure activity. The reason is that there is really a high incidence rate. So for patients, typically about 25% of those presenting with TBI will have a seizure that we're actually able to see. Again, as you'll talk in your seizure disorder, not all seizure disorder or seizures activities are able to be seen with the naked eye. So actually, if we hook a patient up to an EEG, we see that more likely 50% of all patients with severe TBI experience at least one seizure within that 7-day window afterwards. So there is some thought that it might be appropriate for us to treat prophylactically, even in those who have never had a seizure that's been witnessed by the medical staff, particularly in anyone with a Glasgow Coma scale of less than 10. Cortical contusions, if they do have a depressed skull fracture, this is identified as a risk for seizure. Certain hematomas, if they do have a penetrating head wound, this is associated with higher risk. And of course, if they've already had a seizure within the first 24 hours of presentation, they're likely to have additional seizures thereafter. So use of prophylactic seizure medications is really controversial at this time. If you look at the guidelines, they make no recommendation because there's just not enough evidence to show benefit. We actually see that there's no benefit to preventing late onset seizures, so seizures that occur 7 days after the onset of the injury. And while there is some evidence that shows that we can decrease risk of seizures by using prophylactic anti-seizures when it comes to early onset seizures, this has no effect on improving outcomes for the patients. So while it hasn't been associated with increased adverse effects, it doesn't really benefit them in the long run. So it's kind of that risk of, are we increasing costs to the healthcare system and to the patient when it's not really benefiting them? If we are deciding to use prophylactic anti-seizures, we should really only consider them within the first 7 days, and you can consider them in patients who have any of the risk factors listed on the previous slide. It is not recommended 7 days after TBI. This is a common problem that we see post-discharge from the hospital, is that patients aren't actually discontinued off of the anti-seizure medication. They come out after discharge and it's thought that they have a true seizure disorder, and they continue to take anti-seizure medications even though the patient really does not need to be on them, which, as we'll talk about, manifests as neuro complications later on. But if we are going to use anti-seizure meds, the drug of choice is still phenytoin. However, we can also consider carbamazepine. So carbamazepine is an alternative recommended by the guidelines. And then you'll also see some institutions will use Keppra or levetiracetam. It's a lot easier to use than phenytoin, but it is off-label. It doesn't have as much evidence for this particular indication. The only other agent that's really been studied is valproic acid, but that's actually been associated with increased mortality when we use it prophylactically, so we do not use valproic acid for this indication. In terms of VTE prophylaxis, so we know that there's a really high risk of venous thromboembolism in these patients, so when we consider the treatment, there's a lot of risk of the primary brain injury actually causing blood clots to occur in the first place. So this can result as primary pulmonary embolism, which is actually the third leading cause of death in trauma patients who survive the first 24 hours. It's also going to be a high risk of immobility. So a lot of our patients are bedridden for a significant number of days. They might actually be under one of those barbiturate comas, so they might not be moving at all. And we know that severe TBI in and of itself is an independent risk factor for a deep vein thromboembolism. So in terms of prophylaxis, so timing of initiation is also kind of controversial. So when we look at success, typically if we're using mechanical compression in addition to pharmacologic compression, we see that our outcomes are better when we just use mechanical alone. However, we also see a significant increase in intracranial hemorrhage. So oftentimes we try to use only mechanical compression or mechanical stockings to prevent risk of VTE rather than jumping to a pharmacotherapy management. So again, within that first 24 hours, we prefer mechanical interventions. We can consider pharmacologic prophylaxis, so typically this is going to be subcutaneous heparin or low molecular weight heparin. It should be started within 24 to 48 hours or 24 hours after a craniotomy. So some patients will actually undergo that surgery to remove a part of the skull to alleviate that pressure. So of course that in and of itself is going to be a risk factor for bleeds. So we want to wait a full 24 hours after the patient has undergone surgery. Usually the unfractionated heparin is going to be our preferred initial choice. We can use enoxaparin as well, so it's likely more efficacious if we have other injuries present. So if a patient comes in and they have multiple injuries throughout the body, then enoxaparin is probably going to be a preferred agent. But if it's localized just as a TBI only, then unfractionated heparin is the drug of choice. In terms of personalizing pharmacotherapy, so we know that there's a lot of changes in terms of patients with TBI when it comes to pharmacokinetics and pharmacodynamics. So we see a much larger volume of distribution in these patients. We also see a much higher, faster clearance in the liver. And we also want to make sure that we're considering weight-based dosing at all times of our phenytoin and our phenobarbital. If we do use phenobarbital as an alternative, some institutions do that, even though the guidelines do not recommend it. In terms of pharmacodynamic considerations, there's really a wide interpatient variability when it comes to treating ICP. So we know that a lot of times it ends up being a trial and error. So we might not come up with that magic combination first off, so we need to be changing things up rapidly. And in terms of decision to start VTE prophylaxis, we really have to consider the entire patient picture. Now, before we close, I just want to touch on neuropsychiatric problems that are associated with TBI. So this tends to be more of those long-term complications that occur. So when we look at risk factors, so these are the rates of TBI or rates of psychiatric disorders that occur after TBI. So you can see the most common is actually major depressive disorder occurring in about 77% of patients. We tend to see a little bit of a change in the way they present. So patients will, again, have that higher risk of suicidal behavior after the TBI. They kind of become hopeless and helpless, feeling like their life has changed, which it has if they've experienced a severe TBI. So they really have to adapt to a new way of life. We do see increased anxiety as well as substance use disorders, so that's about equally common. We can see PTSD because remember with PTSD, this is actually trauma that's occurred, so many patients will develop those symptoms afterwards. And even some patients will see things like specific phobias, OCD, as well as schizophrenia presenting. Now in that situation, it's probably not true schizophrenia and more so psychosis that's been misdiagnosed. In terms of treatment, there are going to be a number of factors that really affect patient response to treatment. So these are listed here, but I don't really need you to know these specifically, but they do help guide the way that we choose agents depending on the patient's medical history. So when it comes to choosing agents for treatment, we kind of follow the same general principles that we follow for choosing in kind of primary psychiatric conditions. So first of all, making sure that the patient is not taking any medications that can affect their cognition. Now, if they need to be on the medication, sure, continue it. But again, remember, one of the biggest problems that we see outpatient after discharge from the hospital is that patients continue to be prescribed their anti-seizure medication. Now, this could be the hospital giving them a discharge of the anti-seizure, or it could be our mistake on outpatient side as well, seeing that they were treated with an anti-seizure medication, assuming that they have a seizure disorder, and then continuing that anti-epileptic. So we have to be really careful about continuing these treatments that might not be necessary for patients. Some patients, we actually see a spontaneous improvement of symptoms. So that can happen a lot of times. That's usually the way that patients get better, unfortunately. We can use the same kind of non-pharmacologic agents, but typically what we do is we want to be very symptom specific in this case, find out exactly what symptoms the patient is experiencing, and try to identify if they're truly experiencing an organic psychiatric illness, or is this just the effects of the TBI itself. And again, try to use the same drug that you would typically choose for a primary psychiatric disorder, just with the understanding that patients with TBI tend to have a much higher risk for adverse drug reactions, and they also tend to have a much lower success rate, so they tend to be much more refractory. So patients with TBI, even more so, we're going to see a lot of trial and error when it comes to treating these psychiatric illnesses. So you want to be really upfront with the patients, with the providers and their caregivers, so that they understand that it might take a while until you find an agent that works. By the time you find an agent, it might have spontaneously got better anyway. So in summary, TBI is a very common cause of morbidity and mortality. Patients with TBI, we know, are pharmacokinetically and pharmacodynamically unstable and very different from the rest of our population. When it comes to acute management, we're really trying to balance our intracranial pressure and our cerebral perfusion pressure. We want to try to prevent secondary insults. Now, when we're looking at things like seizure prophylaxis and VTE prophylaxis, it is a little bit controversial, so we have to consider patient-specific risk factors, but we do want to treat acute seizures as they occur. And also recall that long-term neuropsychiatric complications are extremely common post-TBI, and we want to be frank with patients that treatments don't always work. A lot of times when it comes to TBI-associated neuropsychiatric disorders, they tend to be much more treatment refractory, so it is a high level of trial and error for these patients. And that does it for me. Good luck on your exams.